All right, Dr. Kimura, here we go.
Okay, so I get started, okay? All right, my name is Jun Kimura. I live in Japan, but work at the University of Iowa, where I am stranded because I cannot go back to Japan. But I'm happy today to talk to you about the principles of nerve conduction studies. So let me tell you that this is where I live, and as you know, Iowa is now an epicenter for this pandemic. We have the worst. we are now, I understand the news that Iowa is top in terms of the new cases per capita. And that happened when the university students all came back. And we should have done it all online, but now it's all on site. And every day we have about 200 students becoming positive. That is not a total number every day. And we had to figure out what to do. And so University Hospital, where I work, is in chaos. But I'm here to talk to you. Okay, so what I'm going to do, I have nothing to disclose. What I'm going to do is this. I'm going to talk about, today I'm going to talk about nerve conduction studies, right? You have two main disciplines, electrodiagnosis. One is nerve conduction study, and the other is electromyography, needle study. Of the two, I believe that the nerve conduction studies are more important. I would say 70% of the time, we make the diagnosis primarily based on the result of nerve conduction study. So that's what I'm going to talk about. I will, over the years, I have developed 5 basic principles on how to do nerve conduction study. And these are listed here. And I think today I'm going to go one by one, right? Let me just go through this very quickly so that you know what's coming up next. First one is a history and physical before the electrodiagnosis. Second, when you stimulate the nerve, you always watch twitch, muscle twitch, because that's the only way you know which nerve is being stimulated. And then number 3, when you stimulate the nerve, you stimulate distally and proximally, and then you compare, right? And so this is number 3. And between the two stimulus site, and I will tell you more in detail, it is a distal stimulation that counts, because that will tell you how many nerve fibers are still alive. And this probably is the most important function of nerve conduction study. Number 4 is the linear or non-linear principles. And when we do segmental study, you compare the amplitude and the latency, and if they are changing linearly, it's normal, and if it's non-linear, therefore it is abnormal, right? And number 5, which is the most important point of all this, is that you have a way to go short segmental stimulation or long passage of the nerve distance. And I'll tell you more about it, although today I have no time to talk about long passage, and so it is mostly short incremental stimulation. So that is a sort of a summary of what I'm going to do. So go back to the principle number 1. Let's talk about history and physical, which of course you know. Before you do electrodiagnosis, you have to take a history and you have to examine the patient. And in fact, I think you need to know roughly what the diagnosis is. If you don't know the diagnosis, it is very difficult to do appropriate electrodiagnosis, because electrodiagnosis simply is an extension of history and physical. We make better localization we make a quantitative statement, and in general, we make it a little more precise by doing electrodiagnosis. But you have to have a diagnosis to begin with. And today, I don't want to spend too much time in here, so I just brought one slide, which I'm going to show you for this section. And this is the classification of neuropathy. Now, when we do nerve conduction studies, we do this mostly to assess neuropathy, right? Many different kinds of neuropathy, but neuropathy nonetheless. Now, neuropathy, you can divide in, there are maybe 2 or 3 very good ways to divide neuropathy. And let me just tell you, I don't have a slide here, but you can divide neuropathy into, let's say, acute, chronic, and subacute. Yes, acute neuropathy, example being a Guillain-Barré syndrome. It happens very quickly. Yeah? Subacute, number of subacute neuropathies like diabetes, for example, and chronic is usually often hereditary neuropathy, like Charcot-Marie-Tooth disease, which is a long-lasting entity. So that's one classification which is very important, because you can tell the diagnosis based on that division. Second classification that we might use, and again I don't have a slide, is depend on which part of nerve axon is affected. We divide it into neuronopathy, meaning cell body is affected to begin with. And also it may be axonopathy, meaning cell body is okay, but the nerve axons are primarily affected. And the third one is a demyelination. Axons are okay, but the myelin sheaths, which cover the axon, are affected. This is the demyelinative neuropathy, right? So this division into 3 is also very important, especially from pathology point of view. But when we do electrodiagnosis, those are the not classification we use. We use this one that you're saying. Neuropathy, the nerve is divided into, again, 3. These things usually come in 3s, I guess. Mononeuropathy, polyneuropathy, and mononeuropathy multiplex. And this is very simple and good, right? Mononeuropathy, of course, is just one nerve. It can be any nerve, though. It can be median nerve, ulnar nerve, radial nerve, peroneal nerve, which is now called fibular nerve, as you know, or tibial nerve. Most common being median nerve, and when you have a mononeuropathy of median nerve, that is affection of median nerve only, it's almost always carpal tunnel syndrome. In our setting, I think in my laboratory, I think 40% of patients that we see regularly is a carpal tunnel syndrome. So this is very important, but it just means that one nerve is affected. In contrast, polyneuropathy, poly means all of them. So all the nerves affected. And there are many different categories of polyneuropathy. Most common is the one associated with systemic disease, like diabetic. And in fact, diabetic polyneuropathy probably constitute about 30% of my clientele. So this is very common. If you add mononeuropathy carpal tunnel, polyneuropathy, diabetic neuropathy, I have about 70% of the patients doing that. But here again, it could be uremic, it could be critical illness, it could be paraneoplastic, many categories. And also, polyneuropathy can be autoimmune, which include Guillain-Barré and CIDP, and it could be metabolic or toxic, like alcoholic neuropathy, or it could be hereditary. This is a large part of our patient, as well as Charcot-Marie-Tooth is included. So polyneuropathy usually means all the nerves, and it also implies two things. One is it is usually symmetrical, although there are certain important exceptions. And the second, it is length dependent, meaning longer the nerve, more affected. So when you have diabetic polyneuropathy, chances are patients come to see you because their toes are numb, not the fingers are numb, right? And so if you have a patient who come to see you and saying that, yeah, I have my fingers tingling, then the first question you have to ask is that, how about your toes? And if he said, nothing wrong with my toes, that usually is not polyneuropathy because it's not length dependent. So then you check carpal tunnel or something like this, right? Now, the third category is uncommon, but more interesting. And this is called mononeuropathy multiplex. And as it just says, mononeuropathy is the same here, one nerve, but multiplex, many of them, all right? But this is different from polyneuropathy because you take history, you realize that this patient has, at the end stage of mononeuropathy multiplex, if you just look at the patient, all the nerves affected, and you say, well, this may be polyneuropathy. But if you take a history, you realize that this patient had median nerve 6 months ago, and then tibial nerve 2 months ago, and something else yesterday. So these are different timing. So one nerve at a time, many of them. That's what this means. And this has a very interesting disease entity, which include multifocal motor neuropathy or hereditary neuropathy with predilection to pressure palsy. And these are demyelinative neuropathy. This is important because multifocal motor neuropathy comes as a differential diagnosis of motor neuron disease. Sometimes you cannot tell unless you do good conduction studies. And the axonal type of mononeuropathy multiplex constitute vasculitis and leprosy, HIV, and Lyme disease. So this can be divided into demyelinative. It's convenient to divide this into demyelinative and axonal degeneration. Yes. So this is the classification we use, and let me tell you why we like this classification when we do EMG. That is because when you have a mononeuropathy or mononeuropathy multiplex, lesion site is very focal. As you know, median nerve, carpal tunnel, median nerve is pinched, compressed at the wrist. And if it's ulnar nerve, cubital tunnel, the nerve is pinched at the elbow. These are very short segments. In fact, I'll show you later that the compressed segment is shorter than less than 1 centimeter in any case. So these are very focal lesions. And the same with mononeuropathy multiplex. This is multiplex, so there are many compression sites, but each one of them is focal, right? So that is a characteristic. In contrast, polyneuropathy, like if you take diabetic polyneuropathy as an example, is a diffuse process. Entire length of the nerve is affected. Sure, it is more distally affected, but entire nerve. And these are two, focal pathology and the diffuse pathology, two very different involvement. And therefore, you have to use different technique when you study mononeuropathy as compared to when you study polyneuropathy. And we use for mononeuropathy and mononeuropathy multiplex short segmental stimulation. And for polyneuropathy, we try to use longer passages like H reflex and FA. So this is a summary of why history and physical is important. You have to decide what to do, right? Okay, so now let's go. So we are done with history and physical. Now the next one, as I told you earlier, is watch twitch. When you stimulate the nerve, you have to watch which muscle twitch. And another number 3 is, are you stimulating distally or are you stimulating proximally to the site of the nerve region? And you need to know that when you stimulate, right? So let's take together an example is the median nerve stimulation at the wrist. Now, when you stimulate the median nerve, I think you usually stimulate median nerve at the wrist here, right? Wrist and elbow, which is not shown. Oh, yeah. When you stimulate the median nerve, did you, and then you usually look at the trace, waveform. But what I'm telling you is that when you stimulate here, you have to see which muscle is twitching. And of course, when you stimulate median nerve here, you evoke action potential in the abductor pollicis brevis, and this some abduct, it comes up, right? But you don't usually watch it, right? But I think it is important. Stimulating at the wrist is no problem because there are the median nerve and ulnar nerve is a fair distance here. So unless you use very high intensity, it's unlikely you stimulate ulnar nerve. So when you stimulate median nerve here, you get abduction of the thumb. But when you stimulate median nerve in the palm, which I recommend very highly, we always do that. When you study median nerve, we always stimulate in the palm. That is because palm is distal to the carpal ligament, where the carpal tunnel syndrome, where the nerve is pinched. Yeah? And we want to stimulate, as I told you earlier, we would like to stimulate the nerve distal to the site of the region, so we stimulate here. But when you stimulate here, there are median and ulnar nerve all together here. And you have to identify whether you're stimulating median nerve or ulnar nerve. And if you stimulate median nerve, some abduct. If you stimulate ulnar nerve, some adduct. Yes? And so that's why, and I forgot to mention that the slides I'm showing here in my talk, I will be demonstrating later on, exactly in the same order. So you can use the same slides. You can look at the same syllabus that I gave you, and we go, and this is demonstrated. But when you stimulate here, if you're stimulating median nerve, thumb abduct. If you're stimulating ulnar nerve, thumb adduct. And this is how it goes. Oh, I don't have a slide picture. Okay, that's fine. Now, so that's one point that you have to watch twitch. Now, another point is the importance, as I already said, importance of stimulating median nerve at the wrist. Because if you stimulate median nerve in the palm, if you stimulate median nerve at the wrist, and you say, well, this is distal stimulation, but it isn't, in case of carpal tunnel, because the lesion site is here. So this is a proximal stimulation, and this is a distal stimulation. And distal stimulation tells you whether the nerve is dead or alive. And this is an example. This is not a carpal tunnel. This is a patient, Chinese women I saw in Beijing, where I go regularly, maybe five times a year, and I see all kinds of patients there. But this patient had multiple myeloma and associated neuropathy, and she could not move the thumb very well. And when we stimulate the median nerve at the wrist, the response was very bad. Elbow, very bad. If these are the only thing you do, you would come to the conclusion that the nerve is already lost and a very small response are recorded. But remember, these are proximal site of stimulation in regard to the carpal ligament. And so what you need to do is to go distal to the site of the lesion, and when you stimulate in the palm, you get a good response indicating that the nerve is still there. There are not very much axonal degeneration, and the weakness that this patient has is a conduction block at the common site of compression. So this is what you get out when you stimulate really distal to the site of the lesion. I suggest that all of you stimulate the median nerve in the palm routinely, right? Yeah, okay, let me tell you, this is another example. A 52-year-old man had a Lyme. You know, in Iowa, we have a few Lyme diseases coming from Wisconsin. This is not a Lyme country, but Wisconsin is, and that's the next door, right? But that's not her problem. She came in and she had a swelling in the lower limb, and somebody put PIC line in the right biceps area for IV antibiotics. You know what PIC line is? Peripherally inserted cardiac, the central catheter. Peripherally inserted central catheter. All right? And that was placed in her right biceps. If you place anything near the right biceps, it's always a big problem because there is a nerve there which is very, before you go that, this patient, the 52-year-old, after the PIC line was placed, she developed this. Now, this is the typical wrist drop, right? And the wrist drop, of course, suggests the radial nerve palsy. But this is more than that. This patient, she is trying to dorsiflex the hand. And when she attempted, the hand deviate to the radial side. And this we call radial deviation. And that's usually indicate, yes, this is the radial nerve, but it is posterior interosseous nerve after the takeoff of the branch of the radial nerve, which is innervating extensor carpi ulnaris, all right? So that's why extensor carpi radialis is intact, and when you have a normal extensor carpi radialis and weak extensor carpi ulnaris, on attempting dorsiflexion, the hand deviate to the radial side. So by just looking at it, so that's why history and physical is important. Looking at it, you know this is the posterior interosseous nerve region. And what's happening here, as you see, radial nerve run down like that, right? And the brachioradialis is here. Extensor carpi radialis is the second one. Now, if you spare this muscle, because it is still coming from the radial nerve, and involve extensor carpi ulnaris, which is not, extensor carpi ulnaris, which comes from the posterior interosseous nerve, then of course the hand deviate to the radial side because you still can use extensor carpi radialis, right? And the elbow in here, you see, PICA line was inserted in here, and that's where, see, this is the biceps, and you have a tendon here, and you notice this nerve, this is a branch, is that right? Posterior, the radial nerve come down, divide into posterior interosseous nerve, which is a motor fiber, and the sensory fiber, which is rather big in this way. And if you put the catheter by error into this tendon area, then you can injure posterior interosseous nerve. And that's exactly what happened. And if that is the case, sensory axon is intact. So if you study sensory potential, it should be normal. Now, big question then is that when you study the posterior interosseous nerve, when you stimulate the nerve distal to the site of the lesion, do you get the response or not? And that is the importance between distal stimulation and proximal stimulation. If you stimulate proximal side, then of course you get no response because the patient is not moving the wrist. But when you don't know is that after distal to the site of the region, you stimulate here, do you get the appropriate dorsiflexion? If the axon survived, you should be able to get the appropriate movement, twitch, and the appropriate muscle action potential. And we see it here. When we did the stimulation, distal to the site of the region, recording from extensor indicis proprius, you get a good response. And if you get a good response with distal stimulation, it's always a good prognosis because that will tell you that axons are still there. No axonal degeneration. Of course, when you stimulate more proximally above the region site, you get no response because there is a conduction block. All right. So this is very important response because you can tell, yes, the axons are not dead, and the prognosis is pretty good, right? Let me get my coffee if I can find it. Where did I put my coffee? Oh, here it is. I found it. Okay, so now let's go to the next slide. And of course, if you do antidromic sensory potential for this nerve, remember, sensory is not involved, and therefore it is always normal. So let me give you another patient for comparison. I think this is a very good comparison. This is a 52-year-old. This patient developed the same kind of symptom, which began following a biceps tendon repair. Remember, it's the same area. Let me go back and see. See, biceps tendon is here. When you repair biceps tendon, your radial nerve running through, and the motor point, posterior interosseous nerve is very close to the biceps tendon. Sensory is away from it. So when you manipulate this tendon and inadvertently injure this nerve, that's the posterior interosseous nerve, sparing sensory, right? So you should develop the same kind of symptom, and sure enough, this is on the other side. This patient developed wrist drop, and on attempt of dorsiflexion, the hand is deviating to the right, exactly the same thing, because the extensor carpi radialis is intact, and the extensor carpi ulnaris is affected. So now the next question is what is the prognosis? In order to decide prognosis, you have to stimulate the nerve distal to the site of the lesion. Remember, this is the principle, and we did that. And when we stimulated the nerve distal to the site of the lesion, recording from posterior, from index propolis, there was no response, which is a bad news because it indicates all the axons are now dead. And the sensory potential, as we discussed, is of course normal because it has taken off more proximally. Right? So this is a contrasting case. In one, both showing posterior interosseous nerve paralysis, but in one case, the first case, when you stimulate the posterior interosseous nerve distal to the site of the lesion, you get a good response, indicating axon survived, good prognosis. The second case, you do the same thing, and you get no response, indicating motor axons are degenerated. So this is a poor prognosis, right? So that is the watch twitch and distal proximal principle. Okay, now let's go to principle number 4, which is a little complicated, but it is very important to understand this because waveform analysis of this sort is really very important in whatever we do in terms of nerve conduction study. What we do is a waveform analysis rather than calculation of conduction velocity, right? So going back to the median nerve, as I told you initially, we stimulate median nerve in the palm, wrist, elbow, and axilla, right? And these are 3-channel simultaneous recording, yes? And we record compound muscle action potential from theta eminence and mostly abductor pollicis brevis. And these 2 channels are antidromic recording from the index finger, and this one is index finger, yes, and this is a middle finger, right? Now, you look at this. When you stimulate in the palm, the thumb twitches appropriately, and you record this from abductor pollicis brevis. As you move the stimulating electrode more proximally, latency, of course, becomes longer and longer in proportion to the distance. But the compound muscle action potential you record from abductor pollicis brevis is about the same, right? But when you look at the antidromic sensory potential recorded from index or middle finger, the action potential is becoming smaller and smaller, and this is really very small, 1/3 compared to the distal stimulation, and this is almost like 1/4 compared to the palm stimulation. You follow what I'm saying? When you stimulate the palm, you get, let's say, this is 20 microvolt. So you say 20, 20, 20, 20. You said more than 100 microvolts in here. But in here, you have only 40 microvolt amplitude. So the question is this okay? Is this normal? Is this abnormal? Yeah. And if I have an audience, I'd ask a question. But since this is Zoom recording, I have no chance to ask here, and I have to tell you. But I have to tell you, this is entirely normal response because this is my arm. I got it from my arm, and this has to be normal, right? But how do you know when you look at this? This one you can tell is normal. How do you know this is normal and this is normal? Well, you know it because when you superimpose, the amplitude change is linear. Remember, we are now talking about the linear, non-linear principle. So what I'm telling you here is that when you do segmental stimulation, if the amplitude changes more or less linearly, it is normal, even if the response with proximal stimulation is so small. Now here, you say that why is it that the response recorded after stimulation of axilla is so small compared to the response elicited with palm? Well, this is a matter of synchronization. When you stimulate in the palm, you know, in the median nerve, you have physiologically fast conducting and slow conducting axons. But if the distance between stimulus point and the recording point is short, whether you have fast or slow conducting axon, it really doesn't matter that much. They all arrive at the target around the same time. But if you go farther away to axilla and stimulate the nerve, because there is such a distance between the stimulus point and the recording point, fast conducting axon arrive the target first, and then slow conducting axon lag behind and come back to here later. In other words, they become desynchronized, right? Now, if become desynchronized, then the different axonal unit arrive one at a time, and it makes first one come here, second one come here, and the third one come here, and it makes duration larger. But the amplitude is smaller because they are not synchronized. But in the first one here, all of them arrive at the same time. Therefore, it's a synchronized response, which is higher in amplitude and shorter in duration. And I hope you get this. When you look at this, you have to know, yes, amplitude is high here, but the duration is short because they are all synchronized. But in here, amplitude is down almost 1/3, but the duration is longer because this is a desynchronized response. So that's the sort of thing that you can tell by looking at the waveform, right? Now, so when you see this though, you should ask yourself, why is it that the muscle action potential do not show the decline like this, and the sensory action potential does show the decline, linear decline. Well, it has to do with the duration of unit potential. And let me tell you this because this is a very important concept. Now, let's take, for the sake of simplicity, let's take a median nerve and suppose there are only two fibers, fast conducting and slow conducting, all right? Okay, this is sort of not real, but we can use it as a analogy, yes? And if you now stimulate, as you do a regular sensory study, if you now stimulate fast conducting axon, one single axon, let's see, at the wrist, all right? Sensory nerve study, you stimulate the nerve and you record from the nerve, right? So when you stimulate the nerve here and record from here, you get what we call unit discharge. This is a unit discharge from one sensory axon. And the unit discharge, although not written in here, unit discharge is 2 millisecond duration. Negative peak is 1 millisecond, and positive peak is 1 millisecond. So this is about 2 milliseconds. Now, when you stimulate the slow conducting axon at the same spot in the wrist, you get dotted unit discharge, which is the same here. But because this is slow, your latency is a little delayed compared to this. Is that right? Okay. But the distance is so short with your distal stimulation. Distance between the stimulus point and the recording point is so short. It doesn't really matter whether one axon is going fast and the other axon is going slow. They arrive around the same time, and therefore, compound sensory action potential is a superimposition of the two single unit potential, and it becomes double in amplitude. I hope you see that, right? But now, when you stimulate the same axon more proximally, at the axilla, for example, you stimulate here, and then you have a latency and the unit action potential. You stimulate here, and you have a latency dotted, but here the distance is so long, slow conducting axon lag behind the first conducting axon, and there will be about 1 millisecond difference. And let me tell you, I'm not making up this time lag. We tested, we asked ourselves, what is the latency difference between the fast conducting axon and the slow conducting axon from the axilla to the fingertip? And we found out it is 1 millisecond, right? So here and here, there's a 1 millisecond difference. If that is the case, if you stimulate both of them together, they superimpose like this. And you notice that the positive peak of the first conducting axon superimpose on the negative peak of slow conducting axon, and they are, and therefore they are opposite in polarity. And if you add them up, you get the phase cancellation. This is what we call phase cancellation. Positive and negative are cancelled, and your compound sensory action potential looks like this. And this is compared to the distal stimulation 1/2. And that's why you get such a major diminution of amplitude by phase cancellation alone. So the next question is, why is it that we don't have it in the motor recording? Well, in motor recording, unit discharge, when you stimulate one motor axon and record from the motor unit, this is the motor unit, right? When you stimulate the motor unit, one axon, and record a group of muscle fibers, motor unit potential is much longer in duration, sometimes 10, sometimes 15 milliseconds, instead of 1 millisecond for sensory. And if the duration is long, then even if you stimulate the nerve more proximally, and therefore 1 millisecond difference between the two recording, fast conducting and slow conducting, 1 millisecond recording for the sensory fibers, 1 millisecond recording, it gives you a phase cancellation because you have a opposite polarity lying up in here. But for motor fibers, which is much longer, if you delay only 1 millisecond, fast conducting and slow conducting axons are still superimposed in phase, and therefore there's no phase cancellation. Now, but if you delay this slow conducting axon, let's say if you induce demyelination here and delay it more, 10 milliseconds, then you delay this in here, and your peak, negative peak may come here. And if that is the case, that negative peak and this positive peak will cancel out. And this is what happened when you have a pathological phase cancellation. In other words, in Guillain-Barré syndrome, one axon may be conducting normally, and the next axon may be conducting 10 millisecond delay. And if that happens, then you have a major phase cancellation and response become very small, but that does not necessarily indicate you have a conduction block. All right? So now let's go to the last principle. And I have a very many slides in here, which I cannot finish today, but it's a short segmental stimulation. When do we use it? Or when the pathology is focal. And let me tell you, let's skip this for the sake of time. When we say short incremental stimulation, we are talking about the inching study. Now, this is the old slide, my hand, and we are recording antidromic impulse here. And we are stimulating median nerve here 1 centimeter apart, 6, 5, 4, 2, 3, 2, 1, and 0. 0 is the distal crease of the wrist. So this is 0, and this way we put minus, and this way proximally we put plus centimeter, all right? So when you stimulate here, record the antidromic impulse, and then move the stimulating electrode 1 centimeter, stimulate again, 1 centimeter again, stimulate again. This is an inching technique. When you do that, you get wrist. You have seen this kind of thing many times by now. But this is 0 is a wrist stimulation. When you stimulate at the wrist, latency, as you know, is roughly 3 milliseconds. But when you stimulate more distally, latency is much shorter. So when you look at this, and this is very old slide, this is one very first time inching was done, you know, in 1978, 70. Maybe it's a little bit earlier. We were doing it about 78, 75, 76, around there. But anyway, so every time you move 1 centimeter, the latency changes. And if you calculate based on 50 meters per second, you realize that every 1 centimeter, latency changes 0.2 milliseconds. Because you divide 1 centimeter by 0.2, you get 50 meters per second, right? And so this is good. I think it's good to remember that 1 centimeter equates to 0.2 milliseconds. So if you have 10 centimeters, what do you have? Well, it equates to 2 milliseconds. right? So this is normal. Why do you know it's normal? Because it's a linear. We just talk about the linear, non-linear principle, right? But if you have this kind of response, bottom part, or this also, you see this is non-linear, right? This is normal, but there's a jump here, and then this is normal again. And this is normal, and jump, and this is normal again. And this is a good slide to look at, because here, these are latency differences between the consecutive stimulus point. As I said, that is 0.2 millisecond, but not exactly. This is listing latency difference, but not exactly, because we make a placement error. But it doesn't matter, yeah? Roughly 0.2 millisecond. And when you come to the compression side, there's a major jump. You see this jump? The latency difference between this and this is more than one millisecond. And that, what does it mean? Well, it means this. When we say carpal tunnel syndrome, we are saying that, well, the median nerve is compressed at the wrist, but it more specifically, it is compressed within 1 centimeter. The other segments are essentially normal. These are all running 50 meters per second, and these are all also running 50 meters per second. From here to here only, it is 9 meters per second, because latency difference for 1 centimeter is 1.2 millisecond. Yeah, this is less abnormality, but you can still tell that the group of responses here and the group of responses here, and there is the jump from here to here, which is always abnormal, right? So that's how the imaging study is done. The advantage of imaging study is that when you do that, you know where the compression is. This is between -4 and -3, and that's exactly here in the red place. And we used to think, when we were doing this a long time ago, 78, 79, surgeons used to think that the nerves are pinched at the wrist, and that's completely erroneous. The nerve is pinched at the distal edge of carpal ligament, exactly -4 to -3, So with this imaging technique, we can tell exactly where the compression site is, and we can tell the surgeon where to go. And the next slide is the reporting form we used to use in those days to make sure that the surgeons know where to go to cut. And this is where the jump is from here to here, and that is -4 centimeter distal from the distal crease. That's where the nerve is pinched. I know we can be very precise on this, right? So that is an advantage of doing imaging study. You can also do imaging study for motor fibers. But in order to do that, I think it is best to record from lumbricalis. If you record from here, abductor pollicis brevis, median nerve stimulation can be curved like this. And it is in general difficult to stimulate curved nerve 1 centimeter apart. And besides, in this setting, you can stimulate the ulnar nerve, and you can still do imaging, because there is the first palmar interosseous also located in this vicinity, and you can record from that after stimulating ulnar nerve using imaging approach. Yes. Okay, so I'm running out of time, but when you do that, let me show you. When you do median nerve recording from here, lumbricalis, start 1 centimeter increment imaging, and you of course get the linear latency change, and the amplitude does not change. And the ulnar nerve is the same, linear change, and the amplitude does not change, right? All right, the next, yes, this is Rodin, right? You know what Rodin, you know the name of the sculpture here? Sculpture here is thinker, denken, thinker. Yeah, that much is easy. You know what he's thinking? I know exactly what he's thinking. You know, I think he's thinking, why is it that my little finger is tingling? Because he's pressing the ulnar nerve here. This is a bad posture for the ulnar nerve, bad position for the median nerve. This is Farren's test, and bad position for the knee, fibular nerve. So he's pinching all three nerves here in this while he's thinking, and I think we should not do the same. So when you stimulate when you compress the ulnar nerve at the elbow, the nerve is very superficial, right? So you can induce ulnar neuropathy, and when it happens, this is usually the first clinically. This is first sign. Claw hand. Ulnar nerve is bent like this because you lose lumbricalis, third and fourth, and you cannot straighten it out. But and then you do nerve conduction study across the elbow. This looks pretty good, but if you superimpose, you know there's a gap between the fourth one and the fifth one, and that's where the compression is. So again, we can be very precise here. We know exactly where the problem is. Sometimes it is subtle like this. Sometimes it is not subtle at all. Here's a major jump. What happened? You can even tell it in this mode. You can tell these are normal, and there's a jump, and these are normal. So what's happening is the conduction velocity from here to here, from here to here, from here to here is 50 meters per second. But the conduction velocity from here to here is probably 10 meters per second. So when we say focal region, we really mean it, within 1 centimeter, yeah? Very slow. And the easiest way to detect it is do imaging study. The same for the leg. I might tell you just the peroneal nerve, or newer term is the fibular nerve. You can press the fibular nerve against the fibular head. And when that happens, normally you get this kind of response. And when you stimulate, when you pinch the nerve at the knee, you develop foot drop, right? Foot drop. And when you have a foot drop, if you do a regular conduction study, you usually stimulate a fibular nerve at the ankle, and you get a good response, and stimulate below the knee, B prime, and this is hit. And you don't know whether this is normal or abnormal because there are only two points. Whether it's a linear or non-linear, you have to have 3 points, right? So you have to stimulate at B here above the knee, and you notice the knee response is very small, and therefore this is now non-linear change of compound muscle action potential, which is always abnormal. But with this kind of study, you can tell, yes, there is something probably wrong at the knee, but you don't know exactly where the knee, the compression is. So then you inch. And when you inch, this is the inching, you notice the marks around the knee, and this is the inch. I think I have a better, yeah, this is the inching. When you inch, this time, latency is pretty much linear. But you notice in superimposition, you notice there's a major drop in amplitude from here to here. From here, where did you go? Okay, from here to here. From here to here. And that's the conduction block, right? But the prognosis is good because when you stimulate distal to the site of compression, you get a good normal response, which always indicates that the axon has survived and you have a good prognosis because this is conduction block. Chances are this is demyelination, and all you need to do is to remyelinate between this and this. That is between this and this, right? So this is a good prognosis. So let me show you, go back. Let me see what, yes. I need to show you a very interesting case, and I conclude. We had a patient, this is 2 years ago now, who came in with the swelling at the wrist on both sides, all right? And complaining of numbness in the numbness of the thumb, index, and middle finger on both sides, all right? So remember, this is a swelling at the wrist. And we thought initially, our surgeons thought that this cyst was compressing on the median nerve, all right, on both sides. So they wanted us to check it using segmental stimulation. So we stimulated in the palm, 2 centimeters apart, this, and this is the distal edge of the swelling, and this is the proximal edge of the swelling. And these are equally divided, right, on both sides. And when you stimulate it there, this is a very abnormal response. This is the wrist at 0. Remember, swelling is above the wrist. This is where the swelling is. Yes? Now, when you stimulate the median nerve distal to the site of the lesion in here, you have a this is abnormal response, very rounded, but the latency is normal. Second shock also gives a normal latency, but it is the third stimuli at 0 point, which gives you very increased latency. When you look at this, you have 2 groups of response. One is here, and the other is here. And when you do that, the region is between this and this, yes? And we can calculate, and the other side is exactly the same. First part is one group, and then from the 0 to +3, and this is the second group. And it looks like slowing is between the distal wrist crease and the palm. And this is the same. This is the distal wrist crease and the palm. This delay is the abnormal. And that's where the carpal tunnel syndrome is. Yeah? But the wrist cyst is located in here, proximally from the distal crease. So under the cyst, nothing is compressed. Under the carpal ligament, major compression. So we call it the carpal tunnel syndrome. And we said that we have to see what that wrist was. And we did the MRI. We didn't have the echography in those days. And we did the MRI. And this is the cyst they are talking about on one side. And this is a cyst on the other side. And if you look at this very carefully, this is where the median nerve is. And so cyst is the median nerve itself. And the diagnosis is that when you have this cyst, yes, this patient has a carpal tunnel entrapment here, yes, and this cyst is a hypertrophic median nerve. Now we know when you compress mostly from ultrasound study, when pinch the nerve, proximal part of this nerve swell, yeah? And this is the extreme case, and it become like a cystic. And after that, we learned that when you have a ganglion in the wrist, which is very common, it's almost always one side or the other side, never in the middle. And so we learned the lesson that, yeah, if you have a cyst in the middle, the chances are it's not a ganglion, it is a median nerve itself. Very, very uncommon. I practiced this kind of thing about 50 years, and this is the first time. And we said, this you never see. And the surprise, next week, when we saw this case, next week, same patient came. Huh? This is another patient, marked diffuse thickening of median nerve in the wrist. And we know when we saw a patient, this is a patient. When we saw this patient, we know right away, without doing anything, it's a median nerve swelling, and this must be a carpal tunnel syndrome. And surely, the carpal tunnel has one group of nerve and one group of response, and here is the compression site, exactly where the nerve is pinched. And the patient did have, again, swollen median nerve, And the people said that these unusual things come together. And indeed, in 2 weeks, we have we have a very unusual case, and I just wanted to show you this. And I think the time is over. So let me finish by saying that the home take message is that we are talking about linear and non-linear, and in daily life, you got to watch non-linear step, right? The same thing with the mononeuropathy or multifocal mononeuropathy. It is a focal region, and you go for the where the money is. And in order to do that, we have to inch along. You stimulate the nerve, short segmental stimulation, and you identify that one short segment where major delay is, and the other segments are all normal. So that's why you use inching technique. And for the long segment, we covered all these 5 points. For the long segment, we use completely different approach, like F-wave and H-reflex, which I would like to talk to you some other time. But today is a short segmental stimulation. I think this is a good place to conclude. Thank you very much. Now, what happened here? Let's see.
Okay, we're back. Yes, we're back now from the little break we had, because we're gonna try to do something that we haven't done it before. Dr. Kimura hasn't done it before, but we are getting him set up right now in his remote location to do a demonstration. So what I'm gonna try to do, and you may have to play with the settings you have, the visual settings you have about what you see in your screen, which little window you see in your screen. You may have to play with that. But what I'm gonna try to do, I'm gonna try to go back and forth in two windows. One will be the window where he is demonstrating, and I hope you see that. And I'm gonna be going to this window now, which is a computer window, where he will be showing you numbers. Okay, so here we go. We're gonna start right now, and Dr. Kimura, you are on.
Okay, so I assume that everybody has heard the talk previous hour, right? So we are going to, yes, we are going to do some of the things I have shown in my hand, and we have Sheila helping me with the electrode, and I have Wendy helping me with the computer. So give me the shock, and I think it's pretty easy if I stimulate myself, unless I come to the difficult point. No measurement, I think. So the first thing I'm going to show you, remember the second principle is watch, twitch, and measure, all right? And so I'm going to stimulate the median nerve in the palm. But before I do that, let me show you how we stimulate the median nerve at the wrist. We go, are you seeing my finger here?
Yes, we can.
Okay, we go 3 centimeters above, and we stimulate here. And can you stimulate there? Yeah. Okay, so we stimulate. You see the twitch? Now don't look at the waveform. Stimulate. You see the twitch, and this is abduction, and that is a median movement. Let me show you ulnar movement, stimulating ulnar nerve here. So again, you see the thumb twitch, adduction. So that is the difference, and you gotta watch that, right? And are they seeing the waveform too? Okay. Now, so stimulating the median and ulnar at the wrist is easy. But stimulating here is not that easy, because median nerve come in and turn around. It's a recurrent branch. Ulnar nerve come in from here, and this is a deep ulnar branch going to AD ductor. So you have to differentiate. And let me show you, incidentally, this is a cathode. Black is a cathode, and this is the anode, and cathode is a stimulating electrode. So if you move from the distal side and stimulate here, okay, give a stimulation. I feel the shock, but nothing move, right? Meaning that the electrode is not on the nerve. If I go a little more here, okay, shock. You see the muscle twitch? Try again. And I can't hear the response, so that's kind of bad.
There you go. I turned it up.
Are you listening to me or what?
Yeah, we can totally hear you, loud and clear. No worries.
When I stimulate, you see the twitch? That's the adduction. So I'm stimulating on the nerve here. But if I go 1 centimeter more proximally, watch the twitch, watch the twitch. See the twitch changes? He's not listening.
Yes, we can see it. Yes, we can see it.
So that's how you find the median nerve stimulation in the palm. All right. So always watch. If you stimulate very high intensity, you use very high intensity. So then both goes, and you saw the response become bigger, and that's because you're stimulating both median and ulnar nerve. So in order to get the median nerve selectively, you have to use maximum, but not supra-maximum, very high intensity. So that's what we do first here, right? So that's a thing, and then let me see. Oh, I should then go to radial nerve. Now I'm going to show you the radial nerve. Can you put it in the radial nerve?
Motor, right?
Motor, yeah. And I think maybe I can get some jelly here.
Oh, yeah? Oh, here.
Oh, here. More than this.
Is that right?
Yeah, that's about right. Maybe it's a little bit more distal. Yeah, okay, that's good. Okay, now the next one is the radial. You remember I showed you the wrist drop? And when the wrist is dropped, when you have a radial nerve palsy, you have a wrist drop, all right? But if it is a posterior interosseous nerve, which is damaged, and that is often the case, as we discussed when you go to the bicep tendon area, then you have a wrist drop, but when you try to dorsiflex, the hand deviates radially. That's because extensor carpi radialis is not innervated by posterior interosseous nerve. It is innervated by radial nerve, and therefore it is spared in case of posterior interosseous nerve lesion, which I showed you, right? So it's deviated like this. But in order to stimulate the radial nerve, we usually go here. Okay. And here it is. You notice, again, I want you to look at the movement. Try again. You see the dorsiflexion, and that is the, so I know I'm stimulating the radial nerve. We are recording from the indices proprius. Radial nerve is difficult. Okay, let's do it again. Okay, that's good. Store that, right? And then you go to here. Can you stimulate here? And then you go to the arm. Yeah, that's good. So radial nerve is difficult to do. Of the 3 motor nerve conduction studies, radial is most difficult. The reason being, when you stimulate the radial nerve here, you have a group of extensor muscles. When you stimulate the radial nerve up here, you have additional extensor muscles. And so those waveforms are not necessarily the same. This looks pretty good. You always have some initial downward deflection, which sometimes you cannot avoid, right? So that's how the radial nerve is stimulated. And when you have a patient who comes with radial nerve palsy, the reason the patient referred to you, the physician already know it's a radial nerve by clinical examination, right? So why do they send you to send the patient to you for diagnosis? Well, they're not sending it to you for diagnosis. They're asking you what the prognosis is. And the injury site is usually around here, as we discussed, in the biceps tendon area. And if you stimulate distal to the site of the lesion, and if you get a good response and good waveform, it's always a good prognosis because that means that axons all survive. If you stimulate above the site of the lesion, regardless of the lesion, you get no response. Of course, there's a conduction block here or axonal degeneration. So in order to tell the difference whether the nerve is dead or alive, you have to stimulate distal to the site of the lesion. And that is the point. And the important thing is to watch the movement, okay? And this I did, now I think we should do sensory for the median.
Median sensor.
Median sensor, comparison ulnar and median. Can we do that?
Yep.
So now we're going to go to sensory nerve for change, and I'm going to ask Sheila to place the ring electrode around the ring finger, and this will this coming.
I don't know. What tape? Let's use that. Yeah, yeah. Here, let's put on.
As you know, the ring finger, the fourth digit has the ulnar and the median. This side, the medial side is ulnar, and the lateral side is the median nerve. And since the finger is a volume conductor, it doesn't matter where you put the pickup electrode. You record from both of them. So this will give you the chance to compare one side to the other side. And let me just show you the median nerve stimulation first. And you can actually, let's do it at the wrist though. So you stimulate here for median nerve. Okay, go, yeah, higher. So this is our median antidromic recording from the ring finger. And you measure the same distance and compare to the ulnar nerve. And this is the ulnar nerve. And when would you put them together? And if you put them together, the latency is exactly the same. And therefore, this is a normal response. All right? Okay, let's try one more time. And let me show you again. Yeah, you can erase that. Let me show you again. I'm going to stimulate median nerve. Okay, try again. Okay, and stay there. And I'm going to stimulate ulnar nerve. Okay, and now this time you superimpose. And there's a difference between median and ulnar nerve. And this is what you find, median nerve being later than the ulnar nerve, more than 0.4 millisecond. Now, how did I develop carpal tunnel syndrome all of a sudden? Can you tell? Can you tell?
You moved your
Yes.
stimulator.
I moved the stimulating electrode for median nerve 2 centimeter more rostrally. And the 2 centimeter add 0.4 millisecond. Remember, 1 centimeter equal to 0.2 millisecond, which is important to remember. And I'm going to show you why we know that. And so let's go here and do inching.
Off of the middle finger?
Of the middle finger and put them all fairly close together. That is easier to do. Now what I'm going to show you is the inching of the median nerve. And this is how the inching was initially developed. And I hope I can do it okay. So
You don't want to be marked?
no, it's okay.
Okay.
So I'm going to go here, okay? Just a minute, I'm sorry. Okay. Now that's good. Stay, take it.
Mm-hmm.
Take it. Increase. Increase a little. You notice that we had to increase the shock intensity a little at the wrist here because there's a thickening of the skin and reduce the intensity.
Are we doing the same one again?
Yeah, the next no,
the
next
next
one. And the next one. Yeah, okay. Can you use the slower sweep so that it, yeah. So this is the roughly, we didn't measure it. We usually measure it every centimeter. I'm doing it every 2 centimeters. What is the word? This is 2 centimeters.
2
right?
centimeters, yes.
Yeah. So I'm doing it every 2 centimeters. So latency changes every 0.4 millisecond each time I stimulate. And it is easier to look at it with superimposition. Are they looking at this? They can see
Yep.
this too?
Yep.
Oh, fantastic. How do they see it? In the scope?
We're remoted in from your computer over there.
Oh, okay.
Mm-hmm.
All right, so this is how the inching technique is done. And once again, let me show you the carpal tunnel here, if I can. Store that. Okay,
Okay.
so let me do the same thing here.
You want me to start over?
No, I want to store that.
Okay.
I want to keep it and
Okay.
start a new one.
Okay.
Okay. Or can you do it?
Yeah, I can.
Okay. Now let's see. I should make it one. Okay. Okay. Now, so this is the. Maybe I can do one more. Yeah. All right. So last 6 traces, which I repeated, I now developed carpal tunnel syndrome between the second and the third. You notice the non-linear jump. Now you can superimpose only that part of one.
Yeah.
That might be difficult to do. Yeah.
Nope, I can do it.
Oh, I see. Okay. Yeah, that's good. Yeah. You notice the manual superimposition that Wendy just did, and between the second response and the third response, which you cannot see it very clearly, but if you look at the peak, there is a major jump, which is more than twice compared to other segments, and that's where the compression is. And believe me, carpal tunnel syndrome look exactly like this. Yes, I just imitated it with the lengthening of the nerve. All right, so that was that. And then this is a motor, lumbricalis. And you can do the same thing. And believe me, from theoretical and practical point of view, if somebody asks me what is the most sensitive way to detect carpal tunnel syndrome, that's inching. No question about it. We don't do it though. We don't do it regularly because there are other very simple ways to make a diagnosis of carpal tunnel. But when it comes to the point, and if you want to know where the pinching is, we always inch, right? Now, this electrode placement, which I hope you can see very well, the active electrode is placed on the lumbricalis. And the lumbricalis, there are 4 lumbricalis. First 2 innervated by median nerve, and the last 2 ulnar nerve. This is the second lumbricalis, so therefore it's a median nerve recording. But this is also on top of the first palmar dorsal interosseous, which is ulnar nerve innervated. And therefore, if I stimulate the median nerve here, you pick up from lumbricalis, and if we stimulate the ulnar nerve from the same distance, you pick up from the palmar interosseous, which is ulnar nerve, and you can compare median and ulnar this way. This is Preston's technique, right? It's similar to the antidromic response from the ring finger. And let me show you that now. Okay, this is median nerve. You watch the thumb twitch. Yeah, the waveform is a little different from abductor pollicis brevis. It's a broader response. Okay. Now I go to the ulnar nerve in the same place, and that's the ulnar nerve. And if you superimpose, it's exact. You know, I don't have a carpal tunnel, right? So it's a normal. And again, let me now store that. Let me now show you carpal tunnel. How can I do that? This is the median nerve, and this is the ulnar nerve. And if you superimpose, you notice the latency difference between the two. And here, the latency difference should exceed 0.5 milliseconds. And sometimes, believe me, lumbar recording is very, very slow, maybe 2 milliseconds away. We have seen such a case yesterday and the day before yesterday. And this technique is especially good when you cannot record from abductor pollicis brevis. So we suggest this highly to do that. And here, this also will give me the chance to inch either median nerve or ulnar nerve motorway. Let me just show you, in the interest of time, ulnar nerve stimulation. This is a little tricky, but let me find out. Okay, you can erase those or whatever you do. Yeah. Okay. Yeah, okay. Take that. Take that. Take that. Take that. Take that. And take that. See, inching is done. Inching, we usually measure very carefully, but inching done is very, very, very quickly, except in the black people who has a very, what do you call, callous, thick skin. Then you may have trouble adjusting the shock intensity. But I have a very soft hand, and so does it look okay though? It's pretty good, yeah. You can even use a slower sweep.
Oh.
Yeah, okay, that makes it. See, this is changing linearly, and again, this is used if you have the Jean's canal compression, then there will be a jump between the successive consecutive response. Maybe I can even try that. Let's try. Okay, store those, and then we go to the next one. Okay. Okay, take that. Take that. Take that. Take that. This is I just did it sort of haphazardly, but if you superimpose RAS4, yeah, superimpose RAS4. Yeah, that's first two. And the next one, that's second two. You notice the non-linear jump between the first stimulus and the first two stimulus and last two stimulus. And that's where the compression is. Believe me, this is just a fake because I increase the distance. But it almost always look like that, right? Okay, so now, we're done. Ulnar nerve, Shira. Ulnar nerve. I think I can go around, yeah.
You gonna put your arm up, or you're just gonna leave it like?
I think I bent. And maybe I should let you stimulate. It's easier. It's not okay. Can you? Yeah. Have a tape or something. This.
It's right in there. Straight ahead there.
Go through.
So what am I taking?
Inching it, yeah.
Taping? What do you want?
Oh,
What do you want
taping, yeah. Taping this. So that it won't go. Yeah. Okay, now in order to do see, for all focal mononeuropathy, my main concern is the inching technique. I don't even have to do regular studies at all if we know where the problem is. I think inching is much better, you know. If we were to invent nerve conduction studies, I don't think we'll do a regular study at all. We do either inching or F-wave. Yeah. But it so happens when we do regular nerve conduction study, those distances we use are usually short enough for compression side and long enough for diffuse process. That's why we can use it, right? And so I don't mind that, but the principle is this. Okay, so you usually bend the elbow like this and then go around. Okay, let's do, I don't know whether you go from distally, proximally or not.
I can't see what I'm doing.
Okay, either way.
If you want to slide out,
do
you can
this.
go around to the other side.
Yeah, okay. So I'm going to change the position here.
No, you gotta stay that way.
Okay.
And I'll reach to the inside of the arm.
Oh, okay.
Can you see his arm okay?
You hear him?
Yes,
Oh, okay, good.
can.
How are you doing? Are you okay?
You are doing very well.
Very good.
I just hope that the way I'm selecting the viewing of the cameras here for you, that
Okay.
everybody can see this properly, but I'm sure they can. And we can see very well also the computer screen, and we can see you. So it's all very good.
All right, so this is the inching for ulnar nerve. Oh, I must have a bad ulnar nerve. There it is.
There we go.
Okay, take that. Take that. Take that. Take that. Take that. That's good. See, this is inching, and again, I think you see that these are running linearly, right? Latency is linear, and amplitude is not changing. But if you have a compression, believe me, it jumps, and you can just look at it, and you don't even have to measure. Yeah, this is very good study. You don't even have to measure the latency because you can look at the waveform. Waveform changes. Okay, now we go to the leg. I show you.
Do you
my
not
leg.
want to do a jump?
Oh, maybe we should do the jump. Okay, maybe we should show you how the okay, take it. Okay, jump. You didn't jump enough. No, that's good. Okay, and then this one, raster mode, sometimes it's difficult to see, but if you superimpose, you know what I mean, where the non-linear change takes place. You see that? That's not bad. Let's do it again.
Okay.
Let's do it again.
I'll jump more.
Yeah, you have to do it. Okay. Okay, jump here. Okay. You see what we're doing here? We are making, yeah, there's the jump there. We are making the jump between the first group and the second group. And sometimes this jump is huge, and you really realize that when you say focal compression neuropathy, it is very focal within 1 centimeter. And the other segment distally, proximally are usually pretty much normal. Yeah? And I'd like you to remember that. Okay, so I'm going to show you my cranial nerve. If I, okay, so let's do, I need some, take the chair and put my foot in there.
Would you rather have my
You know, yeah, maybe.
But I made it.
Okay, so put the fibula nerve for him. And then we do it. There's an inching there.
Can you see the foot okay?
Maybe not.
We can. Let me just make this a little bigger. Let me change the view here.
Maybe we can rotate that.
Here, I can try this.
Oh, okay.
Hold on. All right. I think we can see that better now.
Okay, good. So now we're going to do the peroneal nerve, fibular nerve. And again, the foot drop that we discussed about almost always occurs at the fibula, the head of fibula, because the nerve is very superficial here. And so when you do a patient with foot drop, it is an inching around here, which is a little more difficult because the nerve goes fairly deep proximally above the knee. But if you increase the shock intensity, you should be able to do that.
I'll take it.
Okay, so electrode placement is on the extensor digitorum brevis, and this is the ground, and now Sheila is going to stimulate. And I show you the regular in high interest.
Here. There. Oh, no, it's so pretty small.
No, it's okay.
Okay.
Right. So, and you notice, I want you to again see the movement of the foot. This is particularly important when you're stimulating fibular nerve. If you don't get the response, tendency is to increase the shock intensity, and pretty soon you start stimulating tibial nerve. Then the foot moves very differently. Okay.
That doesn't look like very good.
Okay. So this is the regular way of doing fibular nerve. Now I will show you inching.
But you like the shape of that?
Yeah.
Okay.
No, same shape, right? I cannot see.
It's real choppy. It's dispersed.
Yeah.
Why? Yeah. Okay. This is different. I don't know why the waveform is different. Let's see. Is there any way to prove it?
Can you wiggle your toes? Wiggle your toes.
Huh?
Wiggle your toes. You don't have very big EDB.
You don't have ADV?
Yeah.
Okay. But let's do the inching.
Okay.
Now inching, you usually bend the knee just a little, right? Because so that your skin is soft here, not very tight, and so that you have a better access. Okay.
All right.
Okay.
Okay.
It's moving, but why not? Why no response? You see the foot twitch? So it is. We are stimulating the peroneal nerve. You know it right away. But there's no recording there because something is wrong with the connection. Okay.
And
Okay. Yeah, that's good. Okay. Let's just a minute. Yeah. Did you take it?
Yep.
Oh, that's good. Okay. Take. See how easy it is to do inching. Inching is not very elaborate kind of thing. It's very quick, 5 minutes, if you know what you're doing. But do measure. We are not, in the interest of time, we are not measuring it, but we measure it either 1 centimeter apart or 2 centimeter apart. Okay, so let's do the same and do the jump. Just a minute. Are you ready? Jump at least one. Make sure you go all the way. Otherwise, it won't show.
Oh, that one's pretty hard.
No, that's good. Yeah. Okay. So if you superimpose this one, Sheila on purpose skip the one segment, and therefore we should get the jump between the two. But that's exactly what happens with the demyelination of the segment when you have a compression. It doesn't show very much that. What does it?
It shows, yeah, I mean, it's pretty good.
Okay, so that's how it should look. Now we're going to do the same thing from tibialis anterior, which is actually more important because when you have a foot drop, the muscle which is weak is not the EDB, but it is the tibialis anterior. So put them fairly close together, to make it tight, a little tight. Okay, so now we record, and incidentally, when we do a patient with foot drop, we record the EDB, but also almost always tibialis anterior, which is more important muscle. Let's do the
Inching?
inching. Something wrong with the.
No, it does, but it's in a different setting.
Oh, it's a different setting.
Different, yeah.
Okay, we have a different channel. That's the problem here. And the recording from TA, you notice that the base, it is a broad response because this is a big muscle. But you know, the inching is the same. It won't have.
I got tibial.
Yeah, okay. Inching is the same, and again, this when you are dealing with foot drop, the muscle which is weak is the tibialis anterior, and I think you should always do that. But inching is done like this. Okay, then let's do the.
Want the jump? Want to do the jump?
Yeah, okay, do the jump. Okay, so we're going to show you the jump. What happened there? What is that double peak?
It's tibial.
It's tibial going into, yeah. As there's Wendy and Sheila saying that when you have a double hump there, stimulating electrode is very close to tibial nerve. So you have to correct it. It's a major tibial. Okay, go back down a little. This was not a very good record, but I think the jump is between the first two and the next, from there to there. Yeah. So if you superimpose, this was not very good run, but you can tell that there's the jump between the first two or three and then the next one. Eh? Okay, let's do the tibial nerve. And in I didn't have time to discuss the tarsal tunnel syndrome. Tarsal tunnel syndrome is a tibial nerve running, and around the medial malleolus there is a pinch, and that is a theory, but we don't really see tarsal tunnel syndrome ever. But here again, if there is a focal pathology, you can inch it. So that you have more. Yeah, and then here, go from here like this. Or
So start here.
No, sorry.
Start here.
this is a very good response. Okay, yeah, let's see with a little, yeah, that's better. So this is the, if you're going to check for tarsal tunnel syndrome as a mononeuropathy, I would always inch and see if there is a non-linear shift between the at the compression side. We've done it many, many times. We have never found a case like that. And so that's why I believe that there is no such a thing as a tarsal tunnel. But we can make one. That's a little smaller. I think you need higher intensity. Initial, yeah, take it out.
Okay,
Take
start
it out.
over.
Yeah.
Sorry.
Yeah, okay, take it. Okay. And then you really have to jump, Sheila, to make it look. Yeah, okay, let's see.
Maybe I didn't get it.
Yeah, I think so.
I think between second and the third. But you know, if you are not careful about the electrode placement, you can make anything you want, right? And that's why you have to measure precisely, and you have to measure very carefully on the spot, yeah. And you always watch the movement. It doesn't show much there.
Yeah.
Well, does it show? Yeah, I cannot see. Okay, so this would be tarsal tunnel, but I've never seen it unless I make it come like that. Okay, now I think we have, how much time we have?
How much time do we have?
You can still take a little bit more time. That's not a problem.
I wanted to tell you, I didn't have time to talk about long and short principle. I didn't have time to talk about long.
Take another 15 minutes. How's that?
So let's discuss the F-wave recording. And in order to do that, you see, we've been talking about short segmental stimulation all day today, and that is for the focal pathology. And that applies to mononeuropathy and mononeuropathy multiplex. But when you come to the diffuse process, like diabetic polyneuropathy, those short segmental stimulation, of course, doesn't help. It is more important to get the longer passage. And in order to get the longest passage, there are two ways to do it. One is H-reflex, and the other is F-wave. And can I do H-reflex in this setting? Maybe. So let me show you H-reflex first. And the H-reflex has an advantage because it is a reflex, and it has a sensory afferent and motor efferent. So you cover both sensory and motor conduction study. Electrode placement is here. This is a pickup, right?
Yeah.
Yeah. Because now you record from soleus muscle rather than gastrocnemius. We used to record from gastrocnemius, but we realized that the soleus is much easier. And you stimulate the nerve at the tibial nerve at the knee. You use longer duration, 1 millisecond, and you use very small intensity because you are trying to get the sensory fiber activated, which go back to the spinal cord, make monosynaptic connection to the anterior horn cell, which then comes back to the soleus. And I don't know, I have never done this before on me. So we try. I feel it, but not very much. Is that a motor, right? Is that a motor?
Yep.
There's reduce the intensity of the sound. Maybe I should relax like that. You see the a large F wave and a small H reflex, which is yeah. This is the ground, right?
Yeah.
Maybe put.
No, this is the ground.
Oh, this is the ground.
Yeah.
Oh, I thought black. Yeah, this is a good place. You're
That's
stimulating
Perineal.
peroneal nerve. Now, remember that tibial nerve and
Just let your
peroneal
leg
nerve
go down. There you go.
runs close together. So you have to pick the tibial nerve. And you know it's a tibial nerve because the foot is going down. But Sheila's having trouble getting the H reflex. Maybe because I'm not relaxed.
Just let your leg go. Let it lay in my hand. Go down. Just let it leg go. There you go.
Well, okay, here.
Sorry.
I don't think we have a good luck in here because the M response is so big. Remember, we can measure the H reflex here, but if M response is big, antidromic impulse going back to the spinal cord collide the H reflex, and that's why H reflex is small. Can you do something more?
Let me do something.
If I can, are you, is the cathode moving upward, up direction?
Yep.
Then I try again. Okay, reduce the intensity a little. Reduce the intensity. Then the M goes and H does not come back.
No.
Huh?
Oh,
Well,
there it is.
Take it.
No,
Well, that's okay though.
there was a little one.
Yeah, there's the little one. Yeah, point it. Can you? Is there any way to point it? H reflex. Yeah, top one.
Oh, this one?
Yeah, that's the one above. Yeah, okay, that's a H reflex. We would like to have the H reflex a little bigger, but simply because the M response is so big, it is colliding H reflex,
Oh,
and this is a little. This is not a very good response. But you know, when you are lying on the bed, it is much better. Okay, let's do the F wave. Then we improve. Now, F wave, for a number of reasons, we like tibial F wave. Number one reason, it is a long nerve, longer than the arm nerve, because it's a sciatic nerve. So when we do F wave study, we are looking for the long passage because it's a diffuse pathology. And if it's diffuse pathology, the longer the nerve, of course, more abnormality you accumulate, right? That's one reason. Tibial nerve F wave is very easy. F wave is all, there's such a thing as F wave persistence. F wave persistence of a number of percentage that if you stimulate 100 times, how many F wave you get? If you get 80 of them, persistence is 80. If you get 100 of them, persistence is 100. And tibial nerve is 100 normally. And therefore, if you lose F wave in tibial nerve, you know it's abnormal, right? And that's why we do tibial nerve. And the electrode setup is exactly the same as a motor response, and we stimulate at the ankle. And that 1, 2, 3, 4. And I prefer to do it 10 times, but our technologists never do 10. They usually do 5 and calculate, but that's okay. You know, and the tibial nerve F, now the reason why tibial nerve F wave is so good and the peroneal nerve F wave is so poor, there's a very good reason that very few people know. I think the reason tibial nerve F wave is good is, as you know, below the ankle, all the muscle fibers are innervated by tibial nerve, except one. And that one is extensor digitorum brevis, which is innervated by peroneal nerve. In a way, peroneal nerve has only one muscle, and when you stimulate peroneal nerve, F wave has to come back to that muscle. But when you stimulate tibial nerve, F wave can come back any other muscles except for extensor EDB. And that's why tibial nerve is good. And the F wave is bad for peroneal nerve. So that F wave and moves the line to wherever appropriate. We go to the first deviation from the baseline, which if you cannot see very well, if you superimpose, it is usually easier to see. And latency is what?
52.9.
52, and these things you have to assess according to the height. I'm 172. According to the height, and if you in our setting, we are using Nihon Koden Neuropathies, and in this machine, if you enter the height, then it will give you the normal upper limit, and that should be for me something like 55, 56, or around there. And so this is clearly below the normal, below the normal, is that upper limit or lower limit? And because I don't have neuropathy, but believe me, if you have a neuropathy, F wave is usually the first one to show. So we do that, we like very much. Let's do the peroneal nerve, and then I can show you. And I'm going to show you another thing that people usually don't think about. Okay. But first, let me show you the peroneal nerve. Recording is the extensor digitorum brevis. I think I need to hide it. Oh, okay. So here, I'm pretty good, but I have a fairly good peroneal nerve. But sometimes you notice that there is no response there. Okay. So, compared to tibial nerve, you notice that peroneal nerve is not very constant, right? It's sometimes from the second one from the bottom, for example, doesn't have effort, right? And in many subjects, the peroneal nerve F wave is about 30%, and the tibial nerve F wave is 100%. So we suggest the tibial nerve to use. Another thing is the recording side. We usually record tibial nerve from adductor hallucis, where the muscle is. But electrode placement on the foot doesn't really matter at all. Even if you have the pickup electrode on the EDB, if you stimulate tibial nerve, you get a good effect because there are a lot of tibial nerve innervated muscles in the vicinity. Let me see that. Remember, this is what we're doing. Electrode, pickup electrode is EDB, which is a peroneal nerve. But what I'm saying that when you stimulate tibial nerve, we still get F wave. I hope. That's my theory. I haven't really tried this very hard. Now, this F wave compared to the other one is smaller in amplitude and somewhat prolonged, but you see the F wave in there, right? Oh, you do. Yeah, there's the F wave there, right? And in the superimposition. And this is, and I want you to remember this. When we do nerve conduction, at the last message, when we do nerve conduction study, we select one nerve and we stimulate that nerve. That is very specific. But the recording site is very unspecific. It doesn't matter where you pick up the electrode is, because foot is a volume conductor. And so if the tibial nerve innervated muscle are activated, then that can be recorded from any place, even from the electrode placed on the EDB. And I just want to make sure that everybody understands that. Recording is very non-specific, and therefore stimulation has to be specific. In order to make stimulation specific to the nerve, you have to watch the movement of the muscle, because that is the only way you know whether you are stimulating tibial nerve or peroneal nerve or median or arm. All right? So I think that is a message.
Dr. Kimura, my goodness, it's been so amazing to have you to explain all this to us. This is absolutely amazing. Thank you so much. And And
So
you know,
okay, good to
we
see you.
usually have you in our live symposiums and conferences. This year, because of COVID, we had to do this remotely, but guess what? It worked fantastic. So thank you so much for joining us. Thank you for being willing.
Here, who was the former chief tech, and Wendy is the current chief tech.
And Wendy, thank you so much. You did a fantastic job in helping organizing all this. Everybody who is watching, they appreciate it. Thank you all so much.
Give us a copy of recording sometime.
Yes, yes, we will get to everybody the entire event recorded and give to everybody. Thank you. Bye-bye.
Bye. Okay, you guys, thank you very much.
Maybe you don't have an H